Good morning, everybody.
Good morning, Dr. Paz.
Am I noticing that we have our new fellow Vlad on the line? You're muted, Vlad.
Can you see
Yeah,
me?
Yes, I can. Welcome.
We're here together.
Oh, there's Dr. Mukapade. Looking bright and early. Good. Okay, give it a few moments for everybody else up. I think I see Mohammed there. Welcome, Mohammed.
Oh, thank you, Dr. Bash. Hey, how are you? Sorry, I'm
All
stuck
right.
in traffic. I took the wrong turn on my way to the hospital, so I'm stuck in traffic.
Okay. Well,
I'll be there in 5 minutes.
mistakes get made. That's life.
Sorry.
All right, let's give it another minute or two, and then we'll get going. Oh, so no more Dr. Condon, no more Dr. Barris. Oh, cool. Time to move on, everybody. All right, so today I'm going to give this talk that I give every year on the basics of arrhythmias in children, assessment and management. It's a two-part talk, so we'll give the first half hour today, and then we'll give the second half next week. So excuse me if this is very basic for all of our new fellows and old, but I think it's useful to start at the beginning, and we'll, as in the sound of music, let's start at the very beginning. Okay. All righty. So Dr. Locke, one of my mentors, now retired, was quoted as saying that the EKG is a useless test in pediatric cardiology, except maybe in diagnosing WPW. I hope to disavow you of this belief. Possibly one of the very few things Dr. Locke has said about cardiology that is, in my view, false. For a brilliant man, his one stumble. Okay, so just getting to very simple basics. When we're talking about pediatric arrhythmias, we're talking about the bradycardias, which some people view as the boring arrhythmias, though certainly there are times when it's anything but boring, versus the more exciting tachycardias. And in the realm of tachycardia, there are really two main categories, which are disorders of automaticity and disorders of reentry. There's a third, which is triggered automaticity, but I think practically from a clinical perspective, if one keeps these two general categories in mind, you'll do very well in terms of assessment and management of arrhythmias. So let's just quickly review the normal conduction system. We start up at the sinus node, which is at the junction of the SVC and the high right atrium. Electrical impulse passes across the atrium through multiple little bundles, finally reaching the AV node. The AV node divides into the bundle of His, and then the bundle of His further divides into the right and left bundles. And there are, in fact, two branches of the right bundle, an anterior and posterior branch, going all the way out to the Purkinje fibers. And so we all know that when we're in sinus rhythm, the sinus node has the highest degree of automaticity, and it is basically what is driving our heart. And the impulse starts at the top of the heart, works its way down, just as we know from physiology. Now, we're talking about bradyarrhythmias, and so whenever I think about the heart and any arrhythmia, when I'm asked to see a patient, the first thing that I often do in my mind is I think about this little picture in my mind's eye, and I work my way from the top of the heart down. People can do it in any way, but it's always good to have a little bit of a mental model as you're thinking about arrhythmias. So when we start at the top of the heart and we're thinking about causes of slow heart rate, sinus node dysfunction would be the first one we would think about, just because that's the highest level of the electrical system of the heart. Sinus node dysfunction is extremely rare in patients who have structurally normal hearts, almost never seen. However, it is commonly seen following various forms of congenital heart surgery. Acutely in the ICU, we see this not uncommonly after people who've had AV canal repairs, and more commonly in patients who've had sinus venosus ASD repairs. Sinus venosus ASD repair makes a lot of sense, right? Because in order to do that repair, the surgeon has to put a lot of sutures right along the area where the sinus node is located. So it wouldn't be surprising that patients have slow heart rates afterward due to injury. AV canal repairs, which has not really, to my knowledge, been reported, but is very commonly seen by clinicians, I think is likely due to the fact that there's a lot of retraction in the atriotomy in order to visualize the AV canal defect and repair it. I don't know for sure, but that's my suspicion. It almost always resolves in the perioperative period. However, the more important issue is chronically, patients who've had the so-called mustard or Senning repair for transposition, which is now becoming a historical artifact, but we still have lots of adult congenital patients who've had this operation. Very common cause of sinus node dysfunction, which we'll go over in a moment. But more commonly in our present era, patients who've had Fontans for palliation of single ventricle very commonly will have sinus node dysfunction. So just to remind everybody, the mustard procedure. In the mustard procedure, the surgeon would essentially baffle the superior and the inferior vena cava to the mitral valve, allowing for the left ventricle to be the subpulmonary chamber. And then the pulmonary veins from the left atrium would basically drain behind this baffle. The atrial septum would be opened to allow the baffle, and around the baffle, the veins would drain to the tricuspid, to the right atrium, left to the right atrium, and then eventually the tricuspid valve. And this would allow for, you can see here in this angiogram, this is the SVC and the IVC into the systemic venous atrium, which would be baffled into the left ventricle, out to the pulmonary artery. And the pulmonary veins would be just all draining behind the baffle in. So it's not hard to imagine, though, that if somebody is placing, 59 sutures around the superior vena cava to make this baffle, that there might be an issue with sinus node dysfunction. And in fact, this is a diagram from a paper that's now basically 40 years old from Connie Hayes and Welton Gersony, but this has been repeated. This study has been repeated with, in this case, I think there were only about 300 or 400 patients, but it's been repeated with, administrative databases, all sorts of large databases, and they all look almost identical to this original description, showing that more than 90% of transposition patients who had a mustard operation, if you go out to about 10 years out, almost nobody was in sinus rhythm. And in fact, just last week, I think Christina was telling me that they were catheterizing a patient who had a mustard operation and was sitting in junctional rhythm in the 40s throughout the entire procedure. And that is very, very common amongst that. And this would be a typical example of sinus node dysfunction that we would see on like a Holter monitor, or maybe a telemetry monitor where somebody is sleeping and they just have these very, very long pauses. And this is an example from a case report in a patient 13 years after a mustard repair. But you might be thinking, well, we're not going to see too many mustards in my career. That's true, but it's similarly true in Fontan patients. And you can see here that this is a paper from about 25 years ago. And on the y-axis are the percentage of patients who have sinus node dysfunction. On the x-axis is the number of years after Fontan. And you see that by the time you were about 7 years out from Fontan, roughly almost half of patients had sinus node dysfunction. Now, this paper was written in an era when the most common type of Fontan was a lateral tunnel Fontan. And as you may remember, in the lateral tunnel Fontan, the surgeon is sewing a large piece of Gore-Tex to the right atrium and creating a baffle from the IVC to the SVC. So there were quite a few more sutures, placed between the around the area of the sinus node. It still remains to be seen if the external conduit, more common Fontan that we see today, is going to be associated with lower rates of sinus node dysfunction. There is already some literature suggesting that we see less sinus node dysfunction, but since patients who've had Fontan have had to be cannulated for bypass a minimum of 2 times, sometimes 3 or 4 times, And since cannulation often involves placing an incision around the right atrial appendage or putting a large cannula in the SVC, I think that although it may be that it's going to take 10 or 20 years in an external conduit Fontan, it would be hard to imagine that sinus node dysfunction does not become a serious problem for the Fontan patient, even with an external conduit. But instead of seeing it 10 years out, it might be more like 20 or 30 years out. So this would be, I would say, the most common patient substrate in the present era that we still see a fair bit of sinus node dysfunction, which is the Fontan patient. Now, when we think about going below the level of the sinus node, we've talked about sinus node dysfunction. There are, of course, multiple types of heart block, first, second, and third degree. First degree heart block is usually something that's occurring at the level of the AV node. It can also be related to very large atria, but in general, you should think about first degree block as representing AV nodal disease of some sort. We're getting into second degree block. There's two types. There's Mobitz 1 and Mobitz 2. Mobitz 1 block, which, as you know, we're going to go over this a million times throughout the year, but in Mobitz 1, there is prolongation in the PR interval from beat to beat until finally there's a drop beat. This is almost always occurring at the level of the AV node, and that's in contradistinction to Mobitz 2 block. In Mobitz 2 block, we believe that the block is occurring in the His-Purkinje system. It is a lower degree of block, and it is a more serious form of block. And then there is actually a third form of second-degree block, which is really one of the two, which is a 2-to-1 block. So when patients have 2-to-1 conduction, it clearly is a form of either Mobitz 1 or Mobitz 2, but in the absence of an intracardiac His catheter, it's not possible to know definitively looking at a strip of 2-to-1, whether you're in Mobitz 1 or 2. So sometimes formally we'll say you're either in Mobitz 1, Mobitz 2, or 2-to-1 block, understanding that 2-to-1 block likely represents a form of either Mobitz 1 or Mobitz 2. And we can go over throughout the year how one might ferret out which of those two it could be in the setting of 2-to-1. And then finally, there's third degree block. And third degree block is usually an injury in the His-Purkinje system. It could also be an injury to the AV node. Generally speaking, in AV nodal block, in third degree block, there is no conduction. No P waves are conducted at all. So first degree, easy to remember. All the P waves are conducted, albeit with a long PR interval. Third degree block, no P waves are conducted at all. Second degree block is somewhere in between Mobitz 1 and Mobitz 2, and then, of course, 2-to-1 block. By the way, if anyone wants to stop me or interrupt, I'm happy to answer questions as we move along. Okay, so there are many, many, many causes of heart block. There are many infectious, and this is important because every once in a while someone walks into the office in some form of heart block, and we're always questioning ourselves as to why that might be. So there are many infectious causes, such as myocarditis, which is often reversible, Lyme disease, in certain parts of the world, Chagas disease is the most common. We don't see diphtheria as much, thankfully, because people are immunized, although with the new anti-vaccine campaigns that exist, we may see more of that, unfortunately. And then, of course, endocarditis can injure someone's conduction. There are a number of inflammatory disorders like rheumatoid arthritis or Guillain-Barré that can theoretically cause block. I'm not sure I've seen either of those. The third here, trauma, is by far the most common form of heart block that we see in pediatrics, and that is the trauma from cardiac surgery. By far, if someone ever asks you the question, what is the most common cause of block in a child? It is from trauma from heart surgery. Now, there are efforts afoot to try and reduce that. Some of you may be aware of the efforts in Boston where they're actually mapping the conduction system during most complex repairs in order to avoid placing sutures on critical conduction tissue. But I think even in that setting, the most common cause of block is cardiac surgery. But you can have blunt chest trauma, you can have radiation. Therapy can sometimes cause AV block, although thankfully I've never seen that either. There are multiple neurodegenerative disorders, muscular dystrophy, most common one we see, causing block, Kearns-Sayre syndrome, myotonic dystrophy. There are a bunch of infiltrative disorders like tuberous sclerosis with rhabdomyomas, lymphomas, amyloidosis, and sarcoid. And then there are multiple pharmacological causes of heart block, almost always toxic effects. The most common one that we always worry about is digoxin, because it's the drug that we prescribe with some regularity. At high doses or at the wrong dose, it can cause a heart block. And digoxin, for many, many years, has been probably the single most commonly inappropriately dosed agent. Because it's dosed in micrograms, every once in a rare while, a patient will get a 10-fold dose, and that will almost always cause heart block, at least transiently. Tricyclic antidepressants can cause heart block. Virtually all antiarrhythmic agents in any patient can cause heart block. And then clonidine, which is sometimes used, can also cause heart block. So this is just an example of somebody, 7-year-old with a history of cold symptoms, lethargy, dyspnea, and the echo showing severe dysfunction. What we're seeing here is lots and lots of P waves, but we notice that the R to R interval on the QRS is not changing. And so this would be an example of complete heart block. And, in the differential diagnosis would be, for example, somebody who had viral myocarditis, for example. And that's in contradistinction to this tracing, where we see that the P wave, the PR interval is getting longer and longer and longer until finally we see a drop P wave. This would be an example of a patient in whom there's a first-degree heart block. I'm sorry, Mobitz 1 heart block. I apologize. This is an example of Mobitz 1 heart block. Now, the question that I'm sometimes asked, is this a normal observation? It's normal depending upon the time of day and what the patient is doing. It would not be normal to see Mobitz 1 block in an awake patient who's having their EKG done in the clinic. However, if we saw this type of tracing on a Holter or a Zio patch when somebody was asleep, Mobitz 1 is a normal observation in a healthy person who's either very athletic or someone who is sleeping. You can sometimes see that with some regularity. Now, how do we treat these bradyarrhythmias? Well, you can treat the underlying problem. Of course, the only underlying problems that we can treat are things like Lyme disease, or I guess you could argue that myocarditis is treatable, although nobody really knows for sure. But the bottom line is, if we have postoperative heart block, or if it's due to an irreversible cause, then we will place a pacemaker in the heart. So let me ask Vlad. Vlad, why, if we have a patient who has postoperative complete heart block, and but they're looking well. I mean, their escape rate is, let's say, 70 beats per minute, and it's narrow. And it's very consistent. And we're like post-op day 14, and the patient has a very consistent heart rate, let's say, of 70 beats per minute, but they are in heart block. Why do we put pacemakers in those patients?
Is it to anticipate their potential cardiac needs outpatient once they become more active or something to bridge them?
So you're suggesting that although they're stable, they may develop chronotropic incompetence, meaning they're too slow and they need to be faster. Is that your theory there?
Yeah.
Yeah, well, that's certainly a possible reason. I'll give you half credit for that, for sure. Certainly, you're not going to have chronotropic competence when you're in complete heart block. The real reason, though, that we do this is based on very old literature from really the early 1970s. So today, of course, we would never think of not placing a pacemaker in somebody who we think needs a pacemaker. But in the olden days, and this is, when I was like 3 years old, a pacemaker was gigantic. I mean, it was larger than a present-day defibrillator, maybe even 3 times the size of a defibrillator today. And so putting a pacemaker in any patient was considered a very dangerous undertaking, and particularly in a child. And it was very highly associated with infection, erosion, things of this nature. So in that era, it was still considered clinically acceptable to decide not to pace somebody after congenital heart surgery on the theory that it carried its own very substantial risks. And so people could still do studies. It was still considered ethical to do a study and compare how did children do who had complete heart block following heart surgery, who got a pacemaker versus those who did not. And it turns out that when they followed those patients out to a year, the mortality rate of heart block amongst patients who were not paced was close to 50%. So, so essentially, the point I'm trying to make is that that rhythm that we see that is stable following congenital heart surgery, at least in the olden days when patients had perhaps you could argue that heart surgery was different back in 1970 than it is in 2024. I would hope it is. And maybe the level of block is not as severe, but the bottom line is, based on those data, we no longer will allow a patient to go without a pacemaker in the period following surgery if it's beyond a certain period of time. Because of a concern of Stokes-Adams attack and sudden cardiac arrest. So that's the most important reason. Okay. And this is just an interesting tracing from my former colleague, Dr. Spotnitz. He used to actually put transvenous pacemakers in infants. This has been completely abandoned in the recent era, mostly because of two reasons. First of all, when you put a transvenous lead in an infant, remember that the lead is at least 4 or 5 French, and so that's going to block the vein and cause a venous obstruction, which will be a big problem for a patient who has lifelong heart block. But the other reason that was more important was that pacemakers placed up near the clavicular region of small children are highly associated with infection and erosion because there's just not enough subcutaneous tissue up here. And so, and I might add that extracting a lead that's been placed when you're 9 months old is almost impossible. It becomes so heavily, densely scarified that it is almost, if you ask a person who does extractions for a living and you want to get them really, really nervous, you tell them you have a 10-year-old who's had a lead in for 9 years, that'll get their juices running in a bad way. So today we would, in any small child, we would place leads epicardially. And this is the reason why you'd notice that almost always surgeons will place the generator in the abdomen because the risk of erosion is profoundly lower when that's the case. All right, so let's now talk about tachycardias. And there are really, again, 2 types of tachyarrhythmias clinically, and those are disorders of automaticity and disorders of reentry. I would remind that the calcium channel cell action potential looks something like this. And the areas of highest degree of automaticity in the heart are the sinus node and the AV node. The sinus node has the greatest degree of automaticity. The AV node is probably number 2 in most patients. And some of the common characteristics of automatic arrhythmias are that they heat up and they cool down. There is not an abrupt onset or offset of these arrhythmias. And very importantly, they cannot be DC cardioverted. And sometimes when you really can't tell what the mechanism of the arrhythmia is, the response to DC cardioversion or the absence of a response could be very helpful in making a diagnosis of the arrhythmia or a mechanistic diagnosis. And importantly, automatic arrhythmias are very catecholamine sensitive. And so when we think about clinical examples of tachyarrhythmias, automatic tachyarrhythmias, the most common is, of course, sinus tachycardia. The sinus node pretty much does all the things I just described: slow onset and offset, cannot be cardioverted out of sinus rhythm, is very sensitive to adrenergic tone. But when we think of arrhythmias, probably the 3 most common are ectopic atrial tachycardia, junctional ectopic tachycardia or JET, which we often see or sometimes see following certain types of congenital heart surgery, and then some forms of ventricular tachycardia. The important thing to remember when we're thinking about automatic arrhythmias, and this is an important rule of rhythm in the heart, is that whatever is fastest in the heart always wins. And so in an automatic arrhythmia, an area of myocardium with calcium channel cells are firing at a rate faster than the sinus node. And for that reason, they control the rhythm. So again, the reason that we are in sinus rhythm normally is because the sinus node naturally has the highest degree of automaticity. But if you have certain arrhythmias, that area of tissue will be firing at a rate faster than the sinus node, and that will therefore win and take over the rhythm of the heart. And this is just a clinical example of a 14-year-old girl seen by the pediatrician. Here's an irregular heartbeat, gets an EKG. Patient has been complaining of fainting without palpitations, and an echo is performed showing severely depressed function. And what we're seeing here is this is some kind of tachycardia. The atrial rate's in the range of 140 or so. And there isn't heart block, but there are more P waves and QRSs because the rate is so fast. And this is an example of ectopic atrial tachycardia, which is a very classic automatic arrhythmia. And in EAT, there is atrial ectopy from a single area of atrial myocardium other than the sinus node that is beating at a rate faster than the sinus node. And we don't actually know why patients get EAT. But the most important factor or reason that we care about EAT is because it can result in ventricular dysfunction. Some of you may remember that I've said in the past that, one of the most common animal models of heart failure that's been used to study many, many different agents and treatments for heart failure is to just basically pace a dog or an animal's heart very rapidly for 24 to 48 hours, and it will routinely result in very severe ventricular dysfunction. And in a sense, EAT is the same thing. You have an area that's beating at a rate faster than sinus, and over time that can result in severe ventricular dysfunction. Another example of EAT, of an automatic arrhythmia is this example of JET. So this is a 5-month-old. And what we're seeing here is an esophageal lead, but it could easily just be an atrial electrogram. And what we're seeing here is that the ventricular rate is faster than the atrial rate. There are more V's than A's. And when there are more V's than A's, really the only two major options are either VT or JET. And in this case, we have ventriculoatrial or atrioventricular dissociation because the ventricular rate or the His bundle is firing at a rate faster than the sinus rate. And then this is the last example I'm going to show of an automatic arrhythmia. So this is a 15-year-old who came to the emergency room with palpitations and was in tachycardia. I asked the patient to do some leg lifts in the emergency room to raise the sinus rate. And you can see that as the sinus rate increases, it essentially suppresses what is VT, which actually was Bell-Hassen's left ventricular outflow tract VT. So the VT is suppressed by sinus rhythm transiently, and when the patient put their legs back down and relaxed, the VT took over again. And this was a patient who was non-compliant with their calcium channel blockers, and ultimately I ablated this patient, I think on the same admission. So that's automatic arrhythmias. But the most common form of tachycardia in young people is that of reentry. And reentry represents at least 90% of tachycardias in pediatric populations. And I would remind that in order to have reentry, we have to have 3 major requirements, and this is sort of classic teaching of reentry. First, you have to have 2 pathways that are connected proximally and distally. Second, you have to have unidirectional block in one pathway. And the reason for that is that if you imagine that there's let's say a sinus node up here, if the sinus node beats and can easily go down both pathways at the same time, then both will be refractory and there'll be no way for reentry to occur. So there must be unidirectional block in one pathway. And finally, there needs to be a zone of slow conduction. And the reason for that is that if, for example, you put a premature atrial contraction in here, and let's say it blocks in this pathway, but it can conduct down this pathway, if it were to conduct very rapidly, the other pathway would still be refractory, disallowing reentry. But by having a zone of slow conduction, it allows enough slowing that by the time the impulse comes to the other pathway retrograde, it is no longer refractory. So you need to have a lot of things in order to have SVT or tachycardia as a result of reentry. You have to have 2 pathways. There needs to be unidirectional block to allow for reentry to occur to begin, and there needs to be a zone of slow conduction to allow the other pathway to no longer be refractory and allow reentry to occur. So what are some of the most important characteristics, general characteristics? Well, reentrant arrhythmias can be initiated and terminated with appropriately timed premature beats. Again, if you have a premature beat that takes advantage of a difference in the refractory periods of these two pathways, then it will allow conduction through one but block in the other. So you have to have an appropriately initiated and timed beat. Reentrant arrhythmias can have an abrupt and often have an abrupt onset and termination. And so when assessing an arrhythmia, particularly in a patient who's in the hospital on telemetry, or alternatively, when looking at an ambulatory ECG monitor, such as a Zio or a Holter, we look to see how did the rhythm start and stop, because that can give an important clue to distinguish it from the automatic arrhythmias, which tend to have a slower onset and offset. And finally, reentrant arrhythmias can be successfully terminated, at least temporarily, with DC cardioversion. And one clinical pearl that I would remind you is that if you have a patient in whom you're doing a cardioversion, and if the patient is stable, a very important point, it's always worthwhile running the EKG simultaneous with the DC cardioversion, because, as I said a moment ago, the response to DC cardioversion can be a very important diagnostic tool, and sometimes patients who have reentrant arrhythmias will terminate with cardioversion, but it will resume moments later. But you will be able, if you're running an EKG, to see that there were 5 or 6 sinus beats before the tachycardia resumed, and that would help you diagnostically in sort of distinguishing it from an automatic arrhythmia. So again, if someone is unstable, you just cardiovert them. But if they are stable enough that you have a moment, it's always worth putting on the leads and running the rhythm strip as you're cardioverting. Some of the most important clinical examples of reentrant arrhythmias include accessory pathway or bypass tract mediated tachycardia, with WPW being the classic example. AV nodal reentry is a very common form of reentrant tachycardia. Atrial flutter is a reentrant arrhythmia, and then some forms of ventricular tachycardia are also reentrant arrhythmias. So when we talk about accessory pathway tachycardia, we sometimes refer to that as orthodromic AV reciprocating or AV reentrant tachycardia, and we call it that because you're going normally through the AV node from A to V and then back up the accessory pathway and so on and so forth. Again, the typical route is from the atrium to the ventricle via the AV node and then back up the accessory pathway. It is the most common form of SVT in children or any type of tachycardia, and it's slightly more common in males. This is an example of a patient who has Ebstein's anomaly and intermittent palpitations. On the right-hand panel, we see when the patient's in sinus rhythm, they have this very gigantic P wave, which is typical of patients with Ebstein's anomaly. In tachycardia, though, we don't see that P wave. It's the same exact patient, but what's notable is look how flat the T waves are in sinus rhythm, and look how unusual they are in tachycardia, and that's because we have a retrograde P wave that is superimposed on the T wave here in this example. The peak age of occurrence for SVT or ORT in children is in the first 2 months of age. Roughly 40% of first episodes that can occur this early in life. And the frequency decreases over the first year of life. And interestingly and importantly, 2/3 of infants no longer have clinical tachycardia at age 1. And if you do formal testing on these patients, 1/3 have actually no evidence for accessory pathway conduction. So again, let me emphasize that roughly 2/3 of infants who have SVT will never have SVT again beyond a year of age. That is the most important rationale for why we don't generally want to perform ablations in small infants. There are lots of technical reasons we would rather not, but the most important reason is simply that that pathways will stop conducting, or at least patients will stop having SVT by a year of age. So we almost always try to medically manage these patients on the hope that the pathway will stop conducting. The other peak tachycardia recurrence is there's a small blip around 5 to 8 years of age, but as many of you who've rotated in the cath lab see, The next really big peak is in the 10 to 15-year range, teenagers, and this is why the large majority of patients that we ablate for SVT are around that age. And again, about 40% of patients with tachycardia as a young infant will recur later in life, but again, that means that 60 to 65 will not. This is an example of wanted to talk about WPW, which again is the sort of classic ORT description. It was first described in 1930 and initially was characterized as having a short PR, a bundle branch block on resting surface ECG, and intermittent tachycardia. But really, the bundle branch is really more an example of ventricular preexcitation. So the sinus impulse goes through the AV node, but also is simultaneously going through an accessory pathway. And so the ventricle is being depolarized in two manners, through the accessory pathway and also through the AV node. And the pathway allows for pre-excitation of a portion of the ventricle other than through the common AV node His-Purkinje system, allowing for so-called pre-excitation of a portion of the ventricle. And importantly, and we talk about this a lot, the risk of sudden cardiac arrest or death from WPW is about 1 to 2 per 1,000 patient years. And this is an example of a 15-year-old boy who came in with an insignificant past medical history, was seen in the ER with palpitations. And what we see here in this tracing is a wide QRS tachycardia that is very rapid. Some of the R-to-R intervals are as fast as 300 beats per minute. This is an irregular rhythm, and it is irregularly irregular. So when you see a wide QRS tachycardia that is irregularly irregular, the first thing you want to do is hook on the defibrillator pads. This patient was defibrillated appropriately. And what we see is that the patient actually had WPW. So what we were looking at, and you could tell that, by the way, from the pre-excitation delta waves. So the important thing about WPW is that the mechanism of sudden cardiac arrest is pre-excited atrial fibrillation. So for reasons that are not fully understood, patients with WPW have a higher than normal incidence of atrial fibrillation. And if your accessory pathway can conduct rapidly, which again is not true of all WPW patients, but if you have a slick conducting pathway, the atrial fibrillation can be conducted very rapidly, faster than the AV node could do it, and can result in ventricular fibrillation, resulting in sudden cardiac arrest. And you can see why it's so hard to die suddenly with WPW, and why the incidence of the sudden cardiac arrest and death is not that high in it. It's because you have to have a lot of bad things all at the same time, including the fact that you have to have AFib, which is, although more common in WPW patients, is still very unusual in children. And you have to have an accessory pathway that conducts rapidly. And that's a lot of preconditions. So it can happen. There are certainly many case reports of this, but thankfully is not that common. So important point is that the risk of death is not from SVT or ORT when people have WPW, but it's from rapidly conducted AFib, which thankfully is rare in infants. Digoxin and verapamil are contraindicated in patients who have WPW. And the reason is because it's believed that both agents may theoretically enhance conduction through the accessory pathway, meaning that you could have a pathway that maybe can't conduct very rapidly, but in the presence of digoxin or verapamil, patient could potentially conduct rapidly, resulting in an enhanced risk for sudden cardiac arrest. Importantly, parental education about identifying SVT in children who have WPW is very important. Once parents are made aware of the presence of this potential for this arrhythmia, it's rare that patients come into the ER moribund from SVT. Usually that only happens in children whose family did not know they had it to begin with. This is an example of reentry in an older Fontan patient, 16-year-old with palpitations and dizziness, 10 years after a Fontan for triatresia. And what we see is that, of course, this is a terrible tracing. I really have to update this slide because you can't tell what the rate is. This is only a rate of about 110, but this is atrial flutter, or what we, in the world of electrophysiology, we would say it's intraatrial reentrant tachycardia, or IART. This is a common problem affecting well, it says 12.5 to 26% of patients with repaired or palliated congenital heart disease. I think that's probably true for all together. It's a particular problem among spontan patients. And this is another old literature study that has been reproduced many, many times from my friend Steve Fishberger from back in 1997. On the y-axis is the probability of freedom from atrial flutter. On the x-axis is the years from the Fontan. And you see that by about 20 years out, almost nobody did not have atrial flutter or intra-atrial reentrant tachycardia. This was a study of about 120 patients. Since that time, there have been many similar studies with administrative databases, and basically all of the charts look exactly the same. This curve is very reproducible. The further out you go, the more likely you are to have it. And so when a patient has IART, the reentrant loop is exactly the same as what we just discussed, except the reason you have reentry is that there's a scar creating an anatomical barrier. And so essentially the limbs of the reentry are on either side of the scar. And typically, because you're a Fontan patient, there can be a lot of differences in refractory periods around an atrium. And you can basically have reentry around a scar or between a scar and a common structure such as the crista terminalis, which can serve as a barrier to electrical conduction, allowing for reentry to occur. And there's usually a zone of slow conduction, which is often a target that we'll use when trying to ablate atrial flutter. So just to summarize and to end today, when I'm thinking about mechanisms of tachycardia, in my own mind, I separate them out to the automatic and the reentrant mechanisms, and I work my way down the heart anatomically. And this is just how I think of it. One can do it anyway, but I would recommend just trying to use a similar or at least the same mental model each time you're looking at an ECG. So when we're looking at the level of the sinus node, sinus tachycardia is the automatic, if you want to say, arrhythmia that we see there. But there are rare patients who are affected by sinus node reentrant tachycardia. It's a very rare arrhythmia. Perhaps we'll discuss it later in the year, but there is, in fact, a form of reentry that occurs at the sinus node. At the level of the atrial muscle, when we're looking at automatic arrhythmias, there's ectopic atrial tachycardia and multifocal atrial tachycardia, which is sometimes referred to in pediatrics as chaotic atrial rhythm. And then, of course, we've just discussed that you can have reentry at the level of the atrial muscle, such as atrial flutter or intra-atrial reentrant tachycardia, and then atrial fibrillation, which is usually mechanistically thought of as being reentrant. At the level of the AV node and His-Purkinje system, we've discussed already that jet is the most common arrhythmia affecting that area, which we see often in postoperative patients, or sometimes particularly patients who've had surgery around their His-Purkinje system, such as VSD patients or tetralogy patients. And then AVNRT is the most common form of reentrant arrhythmia around the level of the AV node. It is, in fact, the second most common form of SVT in children, to accessory pathways. When we think about AV reciprocating tachycardia, well, there's no automatic arrhythmia like that, but certainly WPW or patients who have concealed accessory pathways, which I'll remind is just a form of pathway that conducts only retrograde and not antegrade, separating it from WPW. Both of those are forms of reentrant tachycardia, and in fact, the most common forms of reentrant tachycardia. And when we get to the level of the ventricles, you can have either automatic or reentrant tachycardias affecting the ventricle. So the mechanism could be from either, and one would need to look at the tracings in order to try and ferret out the mechanism clinically. Any questions about what we've discussed this morning?
I have a quick question, Dr. Pass.
Sure.
For the flutter and fibrillation, atrial flutter and atrial fibrillation, why do they cause reentry? Is it only if there's a scar, or just on their own? They can
So when we're talking about it, so the first thing to say is AFib, there's a lot of debate amongst adult electrophysiologists regarding the mechanism of AFib, but there's some, I think it's generally believed to be multiple reentrant circuits in the left atrium. And there are many reasons why people have AFib. There are congenital forms of, there are genetic causes, and then there are acquired forms of AFib. Atrial flutter for sure is due to the same thing that we were just talking about, which is, the presence of a scar. But it doesn't have to be a scar. One could have just what one needs to have is areas of conduction block, and there are many anatomical areas of conduction block, such as the crista terminalis, the IVC, the mouth of the coronary sinus. All these areas can be essentially areas of conduction block, and if there is enough difference in refractoriness around these areas, if the tissues of the atrium have differences in their refractory periods, their effective refractory periods, then basically any PAC, if it's timed at the wrong point, can take advantage of that and allow for reentry. So basically, it's not only from scars, it can also be from naturally occurring anatomical block. We don't see atrial flutter very commonly in young people who are healthy and have never had congenital heart surgery, probably because the atria is so healthy in a young person that there is very little difference in the refractory period throughout the atrium. As we grow older, that changes. And if you develop a heart failure or diastolic dysfunction, there can be additional strain on the atrium, which can cause differences in refractoriness throughout the atrium, which enhance your chances of having reentrant arrhythmias.
Thank you.
You're very welcome. All right. Well, Vlad, Mohammed, welcome. We're very, very excited that you're here. I think we're going to have a lot of fun. And just to remind, we do EP conference virtually every Monday morning at 7 in the morning, and we typically go for 30 minutes. Today, a little longer. So next week, we'll talk about, in general terms, treatment of tachycardia. We've talked about diagnosis and mechanism. Next week, we'll talk about treatment. Okay. Thanks. I'll see you guys in Sinai in just a little while.
Thank you.
All day, and welcome again.